In this video, we continue our discussion of hormones normally released from the pituitary gland that can also be administered therapeutically. But this time we find ourselves in the posterior pituitary where the peptide hormone antidiuretic hormone, or ADH, also known as vasopressin, is released. ADH is responsible for regulating the tonicity of the plasma by regulating the amount of free water absorbed by the nephron. So you can imagine that if ADH isn't doing its job correctly, or if it's overproduced, we could have a serious water hazard on our hands. And what better place to learn how to avoid those water hazards than down at the local miniature golf course? You better work on that left hook! Besides strategically placing sand traps and hazards, this course features a central stream that collects any errant golf balls. Yep, this is that same collecting duct from the Mineralo food court. If you haven't noticed yet, we're back at the Nephron Fun Zone and Water Park for one last attraction. The collecting duct of the nephron is not only the site of mineralocorticoid activity and sodium reabsorption, it is also the site of ADH action and free water reabsorption. ADH will be represented by this water boy here making his rounds, ensuring that the golfers keep absorbing that free water and stay hydrated. ADH is a peptide hormone released by the posterior pituitary in response to rising plasma tonicity or falling blood pressure. To emphasize the posterior pituitary, we have the water boy wearing his big water jug backpack posteriorly. ADH possesses antidiuretic properties, of course, but as the name vasopressin implies, it possesses vasopressor properties as well. ADH performs these actions by activating two subtypes of G protein-coupled receptors. V1 receptors are coupled to protein G sub Q, or GQ. So, the first green on this course is labeled V1 and is in the shape of a big Q. Being coupled to GQ means that the V1 receptor activates phospholipase C, forms IP3, and increases intracellular calcium. V1 receptors are found on vascular smooth muscle cells. Activation leads to vasoconstriction and increased blood pressure. I mean, just look at this enraged golfer here. What is that, stroke 15?
Just go home, ball! Are you too good for your home?
I want you to notice that he twists and constricts his golf club like a constricted artery. V2 receptors, on the other hand, are coupled to protein G sub S, or GS. So, the second hole is labeled V2 and is in the shape of a big S. Coupled to GS means that V2 activates adenylyl cyclase and increases cyclic AMP levels. V2 receptors are found on the basolateral membrane of the collecting duct cells in the nephron. Hence, the V2 green is located right next to that collecting duct going right down the middle of the course. Activation of this receptor leads to the translocation of aquaporin 2 from cytosolic vesicles to the luminal membrane of the renal tubule cells. This is represented by the water boy at the collecting duct, translocating a free water bottle into the hands of this golfer here. Now, this is aqua pure water we're talking here, not that mineral-infused crap the other guys are selling. Free water only, to keep you hydrated. So, aquaporin channels reduce diuresis by increased free water permeability and resorption at the collecting duct. It turns out that there are extrarenal V2 receptors found on the vascular endothelium. These receptors will be demonstrated across from the V2 green at the pool hall. Notice we've installed some tile here that looks just like the vascular endothelium. These extrarenal V2 receptors regulate the secretion of coagulation factor 8 and von Willebrand factor, which increase platelet aggregation. Remember that we encountered von Willebrand factor previously during the antiplatelet Little League sketch. That peeling backstop at von Willebrand field signified damaged vascular endothelium when the exposure of von Willebrand factor facilitates the formation of the initial platelet plug. In this sketch, the release of von Willebrand factor is signified by the von Will-Brand sponsored pool tables. And the secretion of factor 8 is represented by the 8 ball, of course. Both of these molecules are stored and released by vascular endothelial cells to aid in coagulation.
Whoa, behind the back? That water boy is so cool.
We'll return to the pool hall a little later. First, let's head back out to the golf course to discuss the role of ADH in the development of diabetes insipidus. Let's say a patient who you're treating for bipolar disorder now has excessive thirst and frequent urination. You check her urine osmolality and it's low even after hours of water restriction. This patient is presenting with diabetes insipidus. She can't concentrate her urine either because she's not producing ADH as seen in central diabetes insipidus, or she's not responding to ADH as seen in nephrogenic diabetes insipidus. Do you hear that sound? The endless trickle of an insipid stream of water? This peeing stone fountain is our recurring sketchy theme for the polyuria of diabetes insipidus. Also, as you'll soon see, the golfers down here are going to be working up quite a thirst as they navigate their way out of these dehydrating sand traps. Take a look at that first sand trap. It looks kinda kidney-shaped, right? That's because it represents nephrogenic diabetes insipidus. This occurs when you release ADH from the pituitary, but it cannot exert its effect at the collecting duct, usually due to the blockade of the ADH receptor by pharmacologic agents or due to a hereditary ADH receptor mutation. Either way, remember that the defect is at the level of the kidney. Also, notice that this frustrated golfer here is ignoring the antidiuretic water boy to emphasize that the nephron is not responding to ADH release. Okay, back to our patient presenting with diabetes insipidus. She had a history of bipolar syndrome and was treated with lithium, a common cause of drug-induced nephrogenic DI. To emphasize lithium's ability to antagonize the action of ADH in the collecting duct, we've included our recurring lithium lift-ium balloons here next to the kidney sand trap. Nephrogenic diabetes insipidus caused by lithium usually resolves following discontinuation of the drug. However, pharmacologic therapy can also be useful. Let me show you what I mean. Do you see this Speedo kid retrieving his ball from the fountain? That chloro Speedo? Those unsightly pasty thighs? He represents thiazide diuretics and their ability to treat nephrogenic DI. Thiazides reduce polyuria and polydipsia in nephrogenic DI through multiple possible mechanisms. For instance, thiazide-induced plasma volume reduction leads to enhanced proximal reabsorption of sodium chloride and water. This avoids having to rely on the terminal collecting ducts for water reabsorption where ADH isn't working too well. But remember, if your patient is on lithium therapy, keep an eye on those lithium levels. Diuretics such as thiazides may reduce renal clearance of lithium and raise plasma lithium levels into toxic range. Oh, remember the almond monger blocking sodium entry at the Mineralo food court? Well, it looks like those almonds are making a comeback here at the mini golf course. They represent amiloride, of course, a potassium-sparing diuretic that can be used to treat nephrogenic DI. Amiloride has been shown to be an effective treatment of lithium-induced DI specifically, which is why this almond cart is rudely pushing that lithium balloon man out of the sketch. Besides blocking sodium entry, amiloride also blocks lithium entry into collecting duct cells. This increases the clearance of lithium, so, once again, monitor those lithium levels. The last treatment for nephrogenic diabetes insipidus we will encounter on this course is NSAIDs, such as indomethacin, represented by our recurring anti-inflammatory fire extinguisher, close at hand in case the roasted almond cart gets a little too roasty. NSAIDs decrease the production of prostaglandins that antagonize the effects of ADH. Alright, focus now on the second sand trap. It's shaped like a brain because it's going to represent central diabetes insipidus. Instead of decreased peripheral responsiveness to ADH, you just aren't releasing adequate amounts of ADH centrally from the pituitary gland. This can be caused by numerous conditions, including trauma, a tumor, or an autoimmune process. To emphasize reduced ADH secretion, we've got a golfer here who's been wandering the sand trap for what seems like days, dying of thirst, reaching out for an antidiuretic water boy, but there's none to be found. Ah, here we go. Some antidiuretic water boys to the rescue. If the pituitary isn't releasing ADH, you can administer ADH exogenously. Hence the antidiuretic water boy entering the scene exogenously coming to her aid.